Good morning and hello all my colleagues and friends and fans. Today I will talk about an important issue in acute medicine or in emergency medicine, and still in the context of the pulmonary renal interaction in disease, but now and today in acute medical conditions, and that is the association of acute lung injury with acute kidney injury. We all know that the acute kidney injury or acute renal failure is a common complication of what we call the acute respiratory distress syndrome or adult respiratory distress syndrome, or the ARDS syndrome. That is acute kidney injury complicating acute lung injury, or the association of acute kidney injury with acute lung injury, to be more right and more specific, because the acute kidney injury might be a complication of acute lung injury, or might be an association due to a single pathology. The same pathology or the same condition which caused the acute lung injury will cause acute kidney injury as a part of what we call the multi-organ failure syndrome, which is commonly seen and met with in critical conditions or life-threatening conditions and critical illnesses, and we see them in acute medical settings in the emergency room and in the ICU and in the CCU. The association of acute kidney injury with acute lung injury, or what we call the ARDS syndrome. Is it the acute kidney injury or the acute renal failure? Is it a complication of the acute lung injury, or rather an association between both organ damage or acute organ insults, kidney and the lung, due to one systemic cause? Especially if we know that the common causes of acute respiratory distress syndrome, they are trauma, burns, and sepsis. And the acute respiratory distress syndrome, or the adult respiratory distress syndrome, it is a sort of acute lung injury due to direct pulmonary and indirect lung injury. The causes of direct lung injury, of course, are pneumonia, especially if the pneumonia is severe, acute, severe, and massive pneumonia. It might cause the acute respiratory distress syndrome. And by the way, the acute respiratory distress syndrome, or the adult respiratory distress syndrome, or the ARDS, is a form of non-cardiogenic pulmonary edema. It is non-cardiogenic pulmonary edema due to acute lung insult, which is associated with acute respiratory failure, and may mandate putting the patient on a ventilator, and is met with in acute conditions, as I mentioned, and I already mentioned them now. The pneumonias is a common cause. Also, inhalation of toxins and chemicals and gases might directly affect the lungs. Also, inhalation of vomitus, that's gastric contents, they may cause ARDS. And also other conditions which might affect the lungs due to indirect injury are the massive blood transfusion, acute hemorrhagic pancreatitis, sepsis, and septic shock, multiple trauma, as it happens in road traffic accidents, trauma, massive trauma to the body, and this multiple trauma will cause acute respiratory distress syndrome, and the patient may present with acute respiratory distress or ARDS. In addition, of course, to lung concussion as a direct cause of lung injury causing ARDS. Mass blood transfusion, transfusion-related lung injury, patients with DIC. Also following bone marrow transplantation, following cardiopulmonary bypass, sepsis and septic shock, as I mentioned, multiple body trauma and or chest, severe chest trauma and lung concussion. Toxins and medications also might cause a form of acute respiratory distress syndrome. So these are the usual causes of acute respiratory distress syndrome, and they might at the same time be associated with or complicated by acute renal injury. As I mentioned, acute renal injury is a common association or a common complication with acute lung injury in patients with critical conditions, which I mentioned already. And here, this might be related to multiple factors, including hypotension, hypovolemia, and nephrotoxic substances. These might all result in or considered as pre-renal causes of acute kidney injury. The acute kidney injury definition is variable. There are various definitions of acute kidney injury. And also about the spectrum and the prognosis of acute kidney injury in clinical practice, but depending of course on the underlying etiology of the acute renal insult or the other systemic cause of acute kidney injury. But in general, it means a rise of serum creatinine and oliguria in the setting of an insult or an underlying or precipitating cause of acute renal shutdown. So the rise in serum creatinine, although there are many other causes of non-renal causes of rise of serum creatinine, we have to put them into consideration, and also the presence of oliguria, although in some conditions we have an entity called non-oliguric acute renal failure. Still, the absence of oliguria does not exclude acute renal injury or acute renal failure or acute kidney injury. But in most of the classic cases of acute kidney injury complicating acute respiratory distress syndrome or ARDS or acute lung injury, there is oliguria and there is a rapid rise of serum creatinine within hours or within days. So there is acute deterioration in kidney functions with oliguria. Also, the acute kidney injury itself might cause or might exacerbate the pulmonary problems because of the traditional complications of acute kidney injury and the what we call non-traditional complications. The traditional complications of acute kidney injury is the electrolyte disturbances and the fluid overload and the uremia. The electrolyte disturbances, the fluid overload and the uremia, especially the among the electrolyte disturbances, the hyperkalemia and the hypocalcemia and the metabolic acidosis and the uremic bleeding and the also the pleurisy. These are all traditional complications of acute kidney injury reflected on the lungs, mostly related to the fluid overload due to the oliguria and related to the electrolyte imbalances and the acid-base disturbances, namely the hyperkalemia and the acidosis and their effects on the lungs and the cardiovascular system. And among the non-traditional complications of the acute kidney injury and their effects on the lungs, and of course their implications on increasing the incidence of pulmonary complications in patients with acute kidney injury are the what we call the respiratory insults due to release of cytokines, which cause some sort of non-cardiogenic pulmonary edema, in addition to the fluid overload, which will cause cardiogenic pulmonary edema. So there are multiple factors biologically or pathobiologically. The fluid overload will precipitate, in addition to the acidosis, will precipitate, and the hyperkalemia, they affect the heart, and they might increase sort or initiate and aggravate the state of cardiogenic pulmonary edema, in addition to the release of cytokines due to a systemic inflammatory response associated with acute kidney injury. And these cytokines will cytokine excess will cause a form of non-cardiogenic pulmonary edema, that is leak of fluid into the lung due to increased alveolar capillary permeability and the flooding of the alveoli with secretions and fluids. So this is the non-cardiogenic pulmonary edema due to cytokine release, and this is among the non-traditional complications. In addition to the other complications related to the systemic inflammatory response, related to the immunoparalysis, what we call immunoparalysis, related to the liver injury complicating acute kidney injury, related also to intestinal injury related to kidney injury. So the intestinal injury, the liver injury, the direct cardiac injury due to the uremic toxins, also in addition to the immunoparalysis and to the inflammatory response causing excess cytokine release and the increasing the non-cardiogenic pulmonary edema. All these are non-traditional complications, in addition, of course, to the effects of acute kidney injury on the hemopoietic system, causing different types of bleeding tendency and coagulation abnormalities. All of these are complications which might increase the pulmonary complications in patients with acute kidney injury. So as we see, it is a mutual bilateral relationship in both directions. The acute respiratory distress might induce or increase or aggravate the acute kidney injury, and the vice versa. The acute renal or acute kidney injury and acute renal failure might increase and initiate a cascade of pulmonary complications related to traditional and non-traditional complications of the acute kidney injury. So this is in general the interaction between the kidney and the lungs in such cases, and in such conditions we have to address and manage the underlying cause, and it's very important in the management of such cases with acute kidney and acute lung injury as a part of multi-organ failure syndrome in critical illnesses, is to number one, address the underlying condition and treat it, including the sepsis, the trauma, the burns, etc., and fix the underlying condition is the most important, and then paying attention to fluid management and avoiding the fluid overload, which might increase the intra-abdominal pressure, or causing what we call intra-abdominal hypertension, and compromise the renal perfusion, and increase the tubular and the glomerular insult, and increase the renal injury and renal failure in such cases. So we have to avoid fluid overload, and we have to avoid at the same time also excess fluid depletion and hypovolemia, which might increase the renal insult. So we should avoid any dehydrating or any hypovolemic factors. We should avoid any toxic factors, including nephrotoxic drugs and nephrotoxic agents, which we might use in such conditions. So, and because this might increase the propensity to acute tubular necrosis and put other insults on the kidney, which make the renal failure multifactorial. Some of them pre-renal, some of them intrinsic renal due to tubular injury or glomerular injury. So we should improve the hemodynamics, we should improve the fluid status, we should give the patient the proper fluid resuscitation, also at the same time avoiding fluid overload, which increases the pulmonary edema. Wise use of diuretics in such cases also is mandatory. Wise use of ventilation and ventilator, and especially low tidal volume ventilation in such patients with acute respiratory distress syndrome, and at the same time paying attention to the electrolyte disturbance, especially the hyperkalemia and the hypocalcemia, and also trying to correct the acidosis, metabolic acidotic state in such conditions, because this increases also the cardiovascular problems and put the patient at risk of other cardiogenic pulmonary edema and other insults to the pulmonary circulation and pulmonary vascular system. So we have to address proper fluid and electrolyte management. We have to address also in addition to the underlying factor, avoiding, as I mentioned, the volume overload, the treatment of electrolyte disturbances, using the renal replacement therapy in the proper time, especially in oliguric cases, and this is by a co-consultation between the intensivist and the nephrologist to select the proper time to start renal replacement therapy in such patients. Also, selecting the proper time for to put the patient on a ventilator for treatment of the acute respiratory distress syndrome, selecting the time for ventilation, and more important, to select the time to wean from ventilator also is more difficult decision than the decision of putting the patient on a ventilator. Especially that we know that many of the complications after when the patient recover, or if the patient recover from the underlying condition and survive, there are complications after acute respiratory distress syndrome, including tracheal fibrosis, tracheal stenosis due to intubation, also sequelae of pulmonary fibrosis related to healing of the underlying lung pathology in patients surviving acute respiratory distress syndrome, pulmonary fibrosis, also the sequelae of post-traumatic stress syndrome, the sequelae of cognitive dysfunction, and other brain problems related to the brain affection, sometimes in such patients with multi-organ failure, as I said. There are such conditions not only associated with acute kidney injury, with acute renal failure, and acute lung injury with acute respiratory distress. They might also have hemostatic failure with consumption coagulopathy. We should pay attention to the blood picture. We should pay attention to the coagulation factors. We should always check the CBC, the platelets, the white BCs and the RBCs in serial counts, because these are affected, and one of the complications also of multi-organ failure and ARDS is consumption coagulopathy with affection of hemostatic failure and bleeding tendency everywhere. So this is very important to consider. We have to consider the body as a whole, the hemostatic system, the kidney, the lung, the electrolytes, the fluids, the underlying condition, the renal replacement, the ventilation. All of these factors are very important in patients with acute kidney injury and acute lung injury, whether in association or as complications of each other in what we call the organ-organ crosstalks in such critical conditions affecting the life of the patient. This is also to spot the light on acute lung injury with acute kidney injury as part of the spectrum of the lung-kidney interaction in disease in clinical practice. Thank you so much and have a nice day.